Welcome to the deep dive. Today we're embarking on, well, quite an ambitious journey, a truly granular exploration into non-Hodgkin's lymphoma, or NHL.
hmm
This isn't just a surface level overview. Our mission is to peel back every layer of complexity, to really delve into the very fabric of this disease, as described in Chapter 108 of Harrison's Principles of Internal Medicine, the foundational text for medical professionals worldwide.
Absolutely. It's a cornerstone text.
We're aiming for an understanding of NHL so thorough, so nuanced, that you'll feel you've truly mastered the information, almost like an elite professional in the field.
Indeed. And what's truly remarkable about this subject, I think, is how our understanding has evolved. It allows for an increasingly personalized approach to this incredibly diverse group of diseases.
Personalized, right.
We're going to explore not just what NHL is, but dig into the intricate why behind its behavior, and crucially, how that deep biological insight transforms everything, from precise diagnosis all the way to sophisticated targeted treatments. It's really a testament to the power of relentless medical inquiry.
Okay, let's unpack this. Non-Hodgkin's lymphoma sounds like a mouthful, but it's a critical area of study. So let's begin right at the core. For someone looking to master this topic, how do we fundamentally define non-Hodgkin's lymphoma? And what's maybe the single most critical distinction that sets it apart?
Right. Well, at its foundation, non-Hodgkin's lymphomas are a diverse group of cancers. They originate from mature B, T, and natural killer, or NK cells. So that cellular origin is absolutely key.
Okay.
Now, the fundamental distinction, the thing that separates NHL from Hodgkin's lymphoma, or HL, is actually quite precise. It's the absence of the Reed-Sternberg cell.
Reed-Sternberg cell.
Yeah. This unique, often multinucleated cell is the diagnostic hallmark of Hodgkin's lymphoma. So when we diagnose NHL, we're essentially saying, okay, this is lymphoma, and it lacks that specific Reed-Sternberg signature.
That's a crucial biological line in the sand then. And that difference isn't just academic, is it? I mean, it must have profound implications for how these diseases actually behave in a patient.
It absolutely does. Profound. This biological distinction points to vastly different natural histories and prognosis. Think about it. For Hodgkin's lymphoma, our success rates are incredibly high. We're talking approximately 80 to 85% of patients achieving a cure with chemotherapy, sometimes combined with radiotherapy.
That's pretty high.
It is. But for NHL, however, the prognosis is far more variable, much more of a spectrum. Some forms are indeed highly curable, absolutely, but others remain incredibly challenging. It just reflects the immense heterogeneity within this single umbrella term, NHL.
And I guess that variability directly shapes how we classify NHL. It suggests it's not really one disease entity, but a whole spectrum, right? How do we categorize such a broad group?
Precisely, you've hit it. NHL is broadly classified based on the type of cancerous lymphocyte involved. Mature B-cell NHL, a mature TNK cell NHL. That tells us the lineage, the origin. But just as important is the growth pattern. Some lymphomas grow really quickly, aggressively, demanding immediate intensive treatment, while others are slow-growing or indolent and sometimes can be monitored for extended periods before any treatment is needed.
Aggressive versus indolent. Got it.
Exactly. And the World Health Organization, the WHO, provides a really comprehensive framework. It's essentially a highly detailed map of lymphoid neoplasms. This allows us to precisely identify and understand the many, many subtypes. And this level of detail is just indispensable for guiding specific diagnostic workups and ultimately finding the right targeted treatment.
That complexity really sets the stage. Let's zoom out now and consider the bigger picture, the scope of NHL. The statistics you alluded to earlier are quite striking. Over 77,000 new cases in the U.S. in 2020, and the incidence continues to rise annually. What does Harrison's tell us about these epidemiological trends, and maybe what might be driving them?
Yeah, the numbers are indeed stark. They paint a clear picture of NHL's significant impact. It's not just the 77,000 new cases in the U.S. in 2020. It accounts for about 4% of all new cancers in both males and females,
4%.
which makes it the seventh most common cause of cancer-related death for both genders. What's even more compelling, I think, is its prevalence compared to Hodgkin's lymphoma NHL's incidence is nearly 10 times that of HL.
10 times.
Yeah.
Wow.
And the trend is alarming. Its incidence has almost doubled over the past 2 to 4 decades and continues to climb by an additional 1.5 to 2% each year.
Doubled. That's a really significant shift. Are there clear reasons identified in the source for this increase?
Well, the source doesn't pinpoint a single definitive cause for this overall rise, but it does explore a range of contributing factors.
Like what?
These include environmental exposures, like certain agricultural chemicals, where there's an observed association with increased NHL incidence. We also know that prior treatment for Hodgkin's lymphoma, especially radiation therapy, can increase the risk of developing NHL later on. Though the precise mechanism, whether it's the original disease or the treatment itself that's still being investigated, it's likely a multifactorial interplay, not just one isolated cause.
So not a simple why, but more like a complex web of potential influences. Are there also demographic patterns, differences in who gets NHL that stand out in the data?
Yes, absolutely. We do observe a slight male-to-female predominance. More critically, though, there's a noticeable racial disparity. Incidence is higher in Caucasians than in African Americans. And this disparity, unfortunately, extends to outcomes, which is a major concern. The 5-year survival rate for African Americans with NHL is 63%, which is significantly lower than the 72% for Caucasians.
That's a big gap.
It is. And it immediately raises important questions. Questions about factors like disparities in access to care, socioeconomic determinants, maybe even potential genetic predispositions. Though it's fair to say the chapter itself focuses mainly on presenting the data rather than offering definitive explanations for that disparity.
Yeah, that's a vital area for ongoing research and obviously public health efforts. What about age as a factor, and how does that intersect with specific subtypes of NHL?
Age definitely plays a significant role. The incidence of NHL rises pretty steadily after age 40, becoming more prevalent as people get older. However, it's also really important to remember that lymphomas are among the most common malignancies seen in adolescents and young adults too. So it's present across the lifespan.
Okay.
Beyond just age, the incidence and the specific expression patterns of different NHL subtypes vary geographically and with age. For instance, T-cell lymphomas are generally more common in Asia, while B-cell lymphomas like follicular lymphoma are more prevalent in Western countries.
Can you give us maybe some vivid examples of those geographic and age-dependent variations?
Certainly. Consider angiocentric nasal TNK cell lymphoma. It's seen with striking frequency in Southern Asia and parts of Latin America. Another compelling example is the NHL associated with human T-cell lymphotropic virus type 1, or HTLV1. That one's concentrated in southern Japan and the Caribbean.
Fascinating.
It really underscores how local factors, whether they're infectious or environmental, can dramatically influence the specific types of lymphoma that manifest in a given region. And tying back to age, we see aggressive lymphomas like DLBCL, Diffuse Large B-Cell Lymphoma, and Burkitt's lymphoma really dominating in children. Whereas in adults, while DLBCL is still common, indolent lymphomas like follicular lymphoma are just as prevalent. If you look at the overall landscape, NHL actually dominates the lymphoid malignancies, accounting for a substantial 62.4%, according to some of the figures in the chapter.
So moving beyond these general trends, let's dig into the specific predisposing factors. You mentioned environmental chemicals, but where it gets really fascinating, I think, is the role of infectious agents. This feels like a huge aha moment for understanding why some people might get NHL.
It truly is, yeah. The connection between certain infections and the development of NHL is one of the most compelling narratives in oncology. Several NHLs have strong, direct associations with specific viruses and bacteria.
Like EBV.
Exactly. Take Epstein-Barr virus, EBV. A very common virus, right? Yet it's profoundly linked to endemic Burkitt's lymphoma in Central Africa. It's also strongly associated with aggressive NHL and immunosuppressed Western patients, primary central nervous system lymphomas, and those extranodal nasal NKT cell lymphomas, particularly in Asia and South America. So it really illustrates how one virus can contribute to multiple distinct lymphoma subtypes, especially when the immune system is compromised.
And it's not just EBV, right? What about other viruses that play a role here?
All right. Human T-cell lymphotropic virus, HTLV1, specifically infects T cells. And in a small percentage of individuals, it directly causes adult T-cell lymphoma, or ATL. What's remarkable here is the incredibly long latency period.
How long?
Well, individuals often contract the virus as babies, maybe through breast milk, but the median age of ATL onset is around 56. So decades can pass between that initial infection and the development of cancer.
Wow, decades.
Yeah. And then there's human immunodeficiency virus, HIV. That's another significant predisposing factor leading to aggressive B-cell NHL. This might be linked to the overexpression of interleukin-6 by infected macrophages.
And it's not only viruses, you mentioned bacteria, and the mechanism there, particularly with Helicobacter pylori. That sounds truly extraordinary.
You're absolutely right, and this is a classic example of how chronic inflammation, rather than direct cellular transformation, can actually drive cancer. Helicobacter pylori, the bacterium famous for causing stomach ulcers, is a key inducer of gastric mucosa-associated lymphoid tissue, or MALT lymphomas, specifically in the stomach.
So how does that work exactly?
The fascinating mechanism isn't that the bacterium directly transforms lymphocytes. No, instead, it incites this vigorous, persistent immune response in the stomach lining. It's this chronic antigenic stimulation, the continuous presence of the bacterial antigens, that ultimately leads to the neoplastic transformation of the lymphocytes caught up in that response.
Okay.
And the evidence is compelling. Patients treated with antibiotics to eradicate H. pylori often experience a remarkable regression of their malt lymphoma. It's just a powerful demonstration of how disrupting that chronic inflammatory trigger can sometimes reverse the disease.
That's incredibly insightful. So it's the body's prolonged response, not the direct infection itself, that sets the stage for the cancer. Are there other notable bacterial associations mentioned?
Yes, there are. Malt lymphomas of the skin have been linked to Borrelia species infections, particularly in Europe. Those affecting the eyes, the ocular nexa, are associated with Chlamydophilus psittaci. And small intestine malt lymphomas can be related to Campylobacter jejuni. Furthermore, chronic hepatitis C virus infection is associated with lymphoplasmacytic lymphoma and splenic marginal zone lymphoma. And human herpes virus 8, or HHV8, that's linked to primary fusion lymphoma, particularly in HIV-infected individuals, as well as multicentric Castleman's disease.
Okay. So beyond environmental and infectious agents, it seems our own immune system, particularly when it's compromised or somehow dysregulated, plays a profound role in increasing NHL risk.
Precisely. Immunodeficiency is a major factor, whether it's inherited like an X-linked lymphoproliferative syndrome, Wiskott-Aldrich syndrome, or ataxia-telangiectasia, or acquired, such as iatrogenic immunosuppression after an organ transplant, or due to HIV-1 infection, it dramatically increases the incidence of lymphoma.
And the evidence for that is strong.
Really compelling. Because in some cases, if the immunosuppression can be reversed, say by reducing immunosuppressive drugs post-transplant, a percentage of these lymphomas can actually spontaneously regress. It's quite amazing.
Wow.
For example, the incidence of NHL is nearly 100-fold higher in patients who've undergone organ transplantation and require chronic immunosuppression. Similarly, acquired hypogammaglobulinemia also significantly bumps up the risk.
And it's not just a suppressed immune system, right? It's also a dysregulated one, like in autoimmune conditions that can predispose someone to NHL.
Yes, that's another really important connection. Autoimmune diseases like Sjogren's syndrome, celiac sprue, rheumatoid arthritis, systemic lupus erythematosus, they're all clearly associated with an increased incidence of NHL.
What types specifically?
Well, while diffuse large B-cell lymphomas are frequently seen in this context, multilymphomas are particularly notable in autoimmune conditions like Sjogren's syndrome affecting the salivary glands or Hashimoto's thyroiditis affecting the thyroid. This strong association just reinforces the idea that prolonged immune dysregulation or chronic stimulation can contribute to the pathogenesis of certain lymphomas.
Okay. And beyond environmental, infectious, and immune factors, is there a genetic predisposition, a familial risk?
There is, although it's often considered somewhat subtle compared to some other cancers. An increased risk of NHL has been observed in first-degree relatives of patients with NHL, Hodgkin's lymphoma, or chronic lymphocytic leukemia, CLL.
How significant is that risk?
Large database studies suggest that approximately 9% of patients with lymphoma or CLL have a first-degree relative with some kind of lymphoproliferative disorder, indicating a familial predisposition. And finally, certain chemical and drug exposures are listed as predisposing factors. These include things like phenytoin, dioxin, phenoxyherbicides, and critically, prior radiation or chemotherapy treatments given for other conditions.
Okay, let's shift gears now and go even deeper, right down to the very blueprint of these diseases. The cells themselves, we're talking immunology and genetics. Where do all these lymphoid cells even come from, and how do errors creep in that lead to cancer?
Right. Well, all lymphoid cells trace their origin back to a common hematopoietic progenitor cell. You can think of it as a kind of master stem cell residing in the bone marrow.
Okay.
This progenitor then differentiates into various blood cell lineages. Through a precisely ordered and sequential activation of specific transcription factors, a cell commits to the lymphoid lineage, ultimately giving rise to either B cells or T cells.
And since about 90% of all lymphomas originate from B cells, let's really focus there for a moment. What happens during normal B cell development that, kind of ironically, makes them so susceptible to becoming cancerous?
This is where it gets really interesting, and it's a crucial aha moment, I think, for understanding oncogenesis. A cell commits to B cell development when it begins to express a master transcription factor called PAX5.
PX5.
Yeah. This triggers a complex transcriptional program that includes a highly dynamic and absolutely crucial process, the rearrangement of its immunoglobulin genes. This involves intricate chromosomal recombination and something called somatic hypermutation, all designed to ultimately create a unique and diverse set of antibodies for that specific B cell. It's an incredibly clever biological process for generating antibody diversity.
So it's a normal, even ingenious biological process,
Right.
but one that inherently carries a risk of error. Is that the idea?
Exactly. That's the crux of it. Most B-cell lymphomas arise precisely because of the error-prone nature of these essential genetic events, the immunoglobulin gene recombination and the somatic hypermutation. While these processes are absolutely vital for generating our diverse antibody repertoire and improving antibody affinity, they also introduce a significant vulnerability.
A vulnerability for what?
For catastrophic errors. Things like chromosomal translocations, where segments of chromosomes break off and rejoin incorrectly. These aberrant translocations can activate oncogenes, those genes that promote uncontrolled cell growth. Or they can inactivate tumor suppressor genes, which normally act like brakes on cell division. This is really the essence of how normal, beneficial cellular processes can directly contribute to malignant transformation. It's a fascinating paradox.
And are there specific genes that are more commonly sort of caught up in these errors in B-cell lymphomas?
Yes, absolutely. The transcription factors MYC and BCL6, along with the anti-apoptotic protein BCL2, are critical regulators in normal B-cell development. So consequently, the genes encoding these proteins are very commonly mutated or aberrantly regulated in B-cell lymphomas.
Can you quickly explain what those do? MYC, BCL6, BCL2?
Sure, MYC is a powerful oncogene driving cell proliferation. BCL6 is involved in shaping the environment where B cells mature, called the germinal center. And BCL2 is an anti-apoptotic protein, meaning it prevents programmed cell death, apoptosis.
So it helps survive when they shouldn't.
Exactly. So when these genes are aberrantly activated or dysregulated, maybe through those translocations we talked about, they provide a powerful growth or survival advantage. And that contributes directly to the uncontrolled proliferation that defines lymphoma.
Okay. What about T cells then? Is this similar mechanism at play in T-cell lymphomas?
For T cells, yes, a similar principle applies. Their commitment to differentiation happens when they migrate to the thymus. There they undergo a parallel process, rearrangement of their T cell receptor, or TCR, genes. This process requires the expression of another master regulatory transcription factor called NOTCH1. Just like in B cells, the development of the mature T cell receptor involves rearrangement and recombination of the TCR loci. And mirroring the B cell situation, this too is an error-prone process, which makes it potentially oncogenic. So that fundamental principle of errors happening during crucial gene rearrangement, it applies to both B and T cell development, contributing to their malignant transformation.
That makes perfect sense. Understanding these cellular processes and their inherent vulnerabilities seems fundamental. But when it comes to actually diagnosing a patient, how do clinicians pinpoint the specific subtype of NHL? You mentioned immunophenotype earlier.
Right. So while the stage of differentiation of a malignant lymphoma, how mature the cell looks under the microscope, actually has surprisingly little prognostic value.
Oh, really?
Yeah, it's interesting. But the antigen footprint, or the immunophenotype, is incredibly diagnostically valuable. This is one of those key insights. It allows clinicians to precisely distinguish between the many specific NHL subtypes.
How do they detect that footprint?
We detect this either by flow cytometry, which uses fluorescently labeled antibodies to identify specific antigens on single cells suspended in fluid, or by immunohistochemical staining of fixed tissue sections using enzyme-linked antibodies. These techniques essentially create a unique signature of cell surface proteins, revealing the cell's true identity and its lineage. And that's absolutely critical for accurate classification and ultimately treatment.
That's fascinating. It's like mapping the cell's precise ID badge. And you also mentioned specific recurring genetic abnormalities. Can you give us some concrete examples of these? And what do they tell us about how the lymphoma might behave?
Certainly, yeah. Beyond just the general error-prone nature of receptor development, specific recurring genetic abnormalities, including these chromosomal translocations and genetic mutations, are true hallmarks of many lymphoid malignancies. These often involve what we call balanced chromosomal translocations, where specific antigen receptor genes are aberrantly fused with oncogenes. This basically creates a permanent on switch for growth.
Can you give an example?
Sure. For example, in Burkitt's lymphoma, we frequently see the T814 translocation. That's read as translocation between chromosome 8 and 14. This specific error involves the MYC proto-oncogene, a powerful driver of cell growth, and the immunoglobulin heavy chain, IgH gene. This fusion means MYC is just always active, driving proliferation.
Okay, MYC and Burkitt's, what about others?
In follicular lymphoma, the T1418 translocation is a classic finding. This involves the BCL2 proto-oncogene and the IgH gene. Now, since BCL2 is that anti-apoptotic protein that prevents programmed cell death, its overexpression due to this translocation means the lymphoma cells just don't die when they should, allowing them to accumulate.
Makes sense.
And for mantle cell lymphoma, the T1114 translocation is the definitive genetic signature. This brings the gene for cyclin D1, or CCDN1, which controls the cell cycle, under the control of the IgH gene promoter, leading to uncontrolled cell cycle progression. These aren't just, arcane genetic codes. They are the precise blueprints that dictate the lymphoma's behavior, and increasingly, the specific targeted therapies we can leverage against them. This is really the essence of personalized oncology unfolding.
So these are specific, identifiable errors that fundamentally drive the disease. Are there also instances where these translocations create entirely new problematic proteins rather than just overexpressing existing ones?
Yes, that's another critical category of genetic abnormalities.
Okay.
Less commonly, chromosomal translocations can produce fusion genes that encode what we call chimeric oncogenic proteins. Essentially, these are new abnormal proteins with cancer-driving functions. A notable example is the T25 translocation, found in anaplastic large cell lymphoma, or ALCL. This fuses the ALK gene and the NPM1 gene. The resulting fusion protein acts like a permanently stuck on switch, relentlessly driving the cell to grow and divide without control, the hallmark of cancer. Another important one is the T1118 translocation found in some malt lymphomas, which fuses the API2 and MLT genes. This leads to activation of a pathway called NFP, which promotes cell survival and proliferation. These specific genetic fingerprints are just critical, both for precise diagnosis and for unraveling the underlying biology of these diseases.
Beyond these specific translocations, gene expression profiling has really revolutionized our understanding, hasn't it? What exactly is that, and what has it revealed about NHL, particularly something like DLBCL?
Yeah, gene profiling using array technology allows us to simultaneously assess the expression levels of thousands of genes within a tumor sample. This technology holds immense promise. It can help identify new pathologic genes, recognize patterns of gene expression that have diagnostic or prognostic significance, and ultimately guide treatment decisions.
What are some successes?
One of the early and most impactful successes in lymphoma with this technology was the identification of previously unrecognized subtypes of diffuse large B-cell lymphoma, DLBCL. These subtypes, which might look quite similar morphologically under the microscope, actually have distinct gene expression patterns. They resemble either germinal center B cells, known as GCB-like, or activated peripheral blood B cells, known as ABC-like.
And these subtle differences in gene expression, they have a very real and significant impact on patient outcomes, don't they?
They absolutely do. Huge impact. Patients whose DLBCLs exhibit a GCB-like pattern of gene expression have a considerably better prognosis than those with an ABC-like pattern. This prognostic difference is so robust that it holds true independently of other known prognostic factors, like the IPI score we'll talk about.
So it adds another layer of prognostic information.
Exactly. And more advanced genetic sequencing techniques have further refined these categories into 5 distinct subcategories. Each differs in its fundamental biology, its specific driver genes, and its prognosis. This will undoubtedly have profound implications for future, even more tailored treatments. Similar insights are also being generated for follicular lymphoma and mantle cell lymphoma.
That sounds like an incredibly powerful tool for refining diagnosis and prognosis. What's the main challenge then in bringing this level of detailed genetic information into routine clinical practice for everyone?
Well, the primary challenge remains providing this highly detailed information in a clinically useful time frame for every patient. While these gene expression profiles offer crucial prognostic insights, telling us, for example, that GCB-like DLBCL generally has a better overall survival than ABC-like DLBCL, they do not currently alter primary treatment recommendations for DLBCL in standard practice.
For you, anyway.
Not yet, but this is precisely where clinical trials come in. They are increasingly stratifying patients by these DLBCL subtypes, recognizing that future treatments will be differentiated based on these genetic signatures. For instance, we're already seeing that agents like the Bruton tyrosine kinase or BTK inhibitor, ibrutinib, show more activity in non-GCB DLBCL in the relapse setting. So while it's definitely shaping the future of treatment, it's not yet dictating frontline decisions for every single patient today.
Okay. So we've defined NHL, we've explored its epidemiology, and we've delved into the profound cellular and genetic mechanisms that drive it. Now let's pivot to the patient's journey. When someone presents with suspected NHL, what's the meticulous initial approach to diagnosis and staging?
Right. Regardless of the specific type of lymphoid malignancy suspected, the initial evaluation must always begin with a meticulous history and physical examination. It's truly difficult to overemphasize how paramount this step is.
Why so critical?
These initial observations are foundational. They help us to confirm a diagnosis or perhaps raise suspicion. They identify any urgent manifestations that might demand immediate attention. They guide us in selecting the optimal further studies needed to precisely characterize the patient's status. And crucially, they allow the physician to begin building rapport and formulating an individualized therapeutic plan. Sometimes, a careful history and physical can even lead us to reconsider an initial diagnosis or offer critical hints of the underlying etiology, the cause of the lymphoma.
So what are the key elements clinicians are specifically trying to uncover during that initial history and physical exam?
In the patient history, critical questions include the duration and the pace of symptoms. This can provide immediate clues, helping to distinguish those aggressive, fast-growing lymphomas from the more indolent, slow-growing ones. The presence or absence of B symptoms is also vital.
Remind us what those are again.
Right, those are unexplained fevers, drenching night sweats, or unintentional weight loss of more than 10% of body weight over about 6 months. We also ask about any localizing symptoms that might point to lymphoma involvement in specific areas like the chest, abdomen, or the central nervous system. And a thorough review of comorbid diagnoses, things like diabetes or congestive heart failure, is essential, as these can significantly impact therapy choices, tolerance, and how we monitor the patient. Then, during the physical examination, the clinician will pay close attention to all peripherally accessible lymph node sites, neck, armpits, groin, carefully assessing their size, their consistency, any tenderness. Liver and spleen size are evaluated, often by palpation. Waldeyer's ring, which is lymphoid tissue in the back of the throat, is meticulously examined. The presence of any pleural or pericardial effusions, that's fluid around the lungs or heart or abdominal ascites, fluid in the abdomen, is carefully noted. And finally, thorough checks are made for any abdominal, testicular, or breast masses, and any cutaneous or skin involvement. All these findings profoundly influence further evaluation and disease management.
Okay. Beyond the hands-on exam, what laboratory studies are routinely ordered to further characterize the disease?
A comprehensive set of lab studies is pretty standard for nearly all patients. This usually includes a complete blood count, or CBC, to assess red cells, white cells, and platelets, routine chemistries, liver function tests, serum protein electrophoresis to identify any circulating monoclonal paraproteins, which can sometimes be seen.
And you mentioned some specific prognostic markers.
Yes, crucially, the serum beta-2 microglobulin level and serum lactate dehydrogenase, or LDH, are both considered important independent prognostic factors in NHL. This means they provide valuable information about the disease's likely course, regardless of other factors, helping us to stratify risk right from the start.
And what about more invasive diagnostic tests? Things like a bone marrow biopsy or a lumbar puncture. When are those specifically indicated?
Good question. A bone marrow biopsy is often performed for staging certain diseases, particularly more aggressive ones or those suspected to be widespread. Its necessity can sometimes be influenced by results from other labs or imaging studies. A lumbar puncture, which involves sampling cerebrospinal fluid from the lower back, is indicated if there are concerning neurological signs or symptoms suggesting CNS involvement.
Or if the risk is high.
Exactly. Or for diseases known to have a high risk of central nervous system involvement. These high-risk scenarios include lymphoma affecting specific sites like the paranasal sinuses, testes, breast, kidneys, adrenal glands, or the epidural space around the spinal cord, as well as highly aggressive histologies like Burkitt's lymphoma. Oh, and one other crucial thing, because HIV and hepatitis B and C infections are known risk factors for NHL, and because some NHL treatments can actually reactivate hepatitis B, which can be life-threatening, all newly diagnosed NHL patients are routinely screened for these viruses. It's a critical safety measure before starting therapy.
Right, absolutely crucial. Imaging studies are also a major component of diagnosis and staging. How do the choices of imaging relate to the specific type of lymphoma being investigated?
The specific lymphoma histology and its clinical presentation are critical in guiding the choice of imaging studies. Computed tomography, or CT, scans usually of the chest, abdomen, and pelvis, and often the neck as well, are essential for accurate staging. They're particularly good for assessing lymphadenopathy, in large lymph nodes, especially in indolent lymphomas.
But for the more aggressive types.
Right. For aggressive lymphomas like Burkitt's, DLBCL, plasmablastic lymphoma, and aggressive T-cell NHLs, positron emission tomography, or PE scanning using 18F-fluorodeoxyglucose, or FDG, is particularly useful and often preferred.
Why is PE so exceptionally valuable for those aggressive types? What does it show?
FDG-PT is highly sensitive for detecting both nodal and extranodal sites involved by NHL. This is because rapidly growing cancer cells are metabolically very active and they avidly consume glucose, which is what FDG mimics.
So they light up on scan.
Exactly, they light up brightly. And the intensity of this FDG uptake, which we measure using something called the standardized uptake value, or SUV, actually correlates with the lymphoma's histologic aggressiveness.
Oh, that's useful.
Immensely useful. For example, when transformation of an indolent lymphoma to a more aggressive form is suspected, a much higher SUV in a particular area would strongly raise that flag. PET scanning is also excellent at differentiating between treated, inactive disease and residual active disease, especially if a patient has persistent masses seen on CT scans after therapy. It helps tell us if that mass is just scar tissue or still active lymphoma. There are actually established consensus recommendations for PET scanning from an international harmonization project. These guidelines state that PET should primarily be used for staging and response assessment in FDG-avid lymphomas like DLBCL and Hodgkin's lymphoma. They suggest that scanning during therapy should generally only be done as part of clinical trials.
And after therapy.
End-of-treatment scans should ideally be performed between 3 and 8 weeks after chemotherapy, or maybe 8 to 12 weeks after radiation or chemoradiotherapy, to ensure maximum accuracy and avoid false positives from inflammation. While long-term follow-up usually doesn't include routine PE scanning, a newer finding indicates that PE scan results at the end of therapy for follicular lymphoma are now associated with prognosis. Residual PET avid disease predicts a poorer outcome there.
Okay. And what about MRI? Where does that fit in?
Right. Magnetic resonance imaging, MRI. It's particularly useful for detecting disease in bones, bone marrow, and the central nervous system, so the brain and spinal cord. It provides superior soft tissue contrast compared to CT in those areas.
Got it. So once all this diagnostic information is meticulously gathered, the history, exam, labs, imaging, biopsy, how is the disease definitively staged, and how is prognosis determined? I know the Ann Arbor system is widely used, but I've heard it has recognized limitations for NHL, right?
That's exactly right. The Ann Arbor staging system, which was originally developed for Hodgkin's lymphoma way back in 1971, was subsequently adapted for NHL. It focuses on the number of tumor sites, whether nodal or extranodal, their location relative to the diaphragm, above, below, or both, and the presence or absence of those systemic B symptoms we talked about earlier.
But it's not perfect for NHL.
While it's foundational, this purely anatomic-based system is indeed less useful for NHL. That's because, unlike Hodgkin's, which often spreads predictably from one lymph node group to the next, NHL tends to disseminate widely and not necessarily in a stepwise fashion. In fact, a majority of NHL patients, maybe 60–70%, already have advanced stage disease, stage 3 or 4, at diagnosis.
So the stage number itself isn't as predictive.
For most NHLs, yes. Apart from very early stage disease like stage I, where local radiation might be curative, the specific histology, the exact subtype of NHL, and other key clinical parameters of presentation are actually more important than the Ann Arbor stage itself in predicting prognosis and guiding treatment.
Okay. So what does this all mean for predicting outcome in NHL, especially for the more aggressive types? This is where the International Prognostic Index, or IPI, really steps in, isn't it?
Absolutely. This is where the International Prognostic Index, or IPI, becomes perhaps the single best predictor of outcome for aggressive NHLs like DLBCL. The IPI was rigorously developed from a huge analysis of over 2,000 patients with aggressive NHLs who were treated with standard anthracycline-containing chemotherapy, like CHOP.
And what factors does it include?
It identifies 5 crucial independent prognostic factors. First, age, simply whether the patient is 60 or younger versus older than 60. Second, serum LDH levels, whether they are normal or elevated above the upper limit of normal. Third, performance status using the ECOG scale, basically a measure of the patient's general functional capacity, 0 or 1 versus 2 to 4. Fourth, the Ann Arbor stage 1 or 2 versus 3 or 4. And fifth, the number of extranodal sites involve less than 1 site versus 1 or more sites.
5 factors. And how do these translate into a patient's actual prognosis? How is the IPI score used in practice?
It's pretty straightforward. A single point is awarded for each adverse risk factor present. So older age gets a point, Elevated LDH gets a point, poor performance status gets a point, advanced stage gets a point, and more than one extranodal site gets a point. These points are summed up, giving a score from 0 to 5.
And that score defines risk groups.
Exactly. It defines 4 distinct risk groups, each with a very different outlook based on the original study data. A score of 0 or 1 indicates low risk. 2 is low intermediate risk. 3 is high intermediate risk. And 4 or 5 points signify high risk.
What were the survival rates associated with those?
In the original pre-rituximab data, for patients with scores of 0-1, low risk, the 5-year overall survival rate was an encouraging 73%. However, this dropped significantly to 51% for those with 2 factors, low intermediate, 43% for 3 factors, high intermediate, and a pretty stark 26% for those facing 4 or 5 adverse factors, high risk. It's also worth noting there's an age-adjusted IPI specifically for younger patients.
The treatment has improved since then, right, with rituximab?
Massively. Critically, the addition of the anti-CD20 antibody rituximab to chemotherapy regimens, creating RCH1, has profoundly improved these outcomes across all risk groups. For example, looking at more modern data with RCHOP, for patients with 0 risk factors, the 4-year progression-free survival rate can now be as high as 94%. That compares to maybe 80% for 1-2 risk factors, and still around 53% for those with 3 or more risk factors.
Okay.
Much better, but the IPI still clearly stratifies patients.
That's a huge improvement. So a powerful and widely adopted tool for aggressive lymphomas. Are there similar prognostic indices for other significant NHL types, like follicular lymphoma?
Yes, there is. Recognizing that different lymphomas behave differently, specific indices have been developed. The Follicular Lymphoma International Prognostic Index, or FLIPI, is a similar predictive model specifically developed for follicular lymphoma, derived from an even larger cohort of over 4,000 patients.
What factors does FLIPI use?
Its independent prognostic variables are slightly different but overlap somewhat. They include age over 60, stage 3 or IV disease, having more than 4 nodal sites involved, an elevated serum LDH concentration, and a low hemoglobin level, specifically below 12 GDL. Summing these variables again identifies 3 risk groups, low, intermediate, and high, with 10-year survival rates in the original study ranging from about 71% for low risk down to 36% for high risk. Similar disease-specific IPIs have also been developed for mantle cell lymphoma, the MIPI, which even incorporates biological factors like the proliferative index, and for peripheral T-cell lymphoma.
And just circling back quickly to the gene expression profiling we discussed earlier, does that tie into prognosis in a clinically useful way yet, beyond just informing research and trials?
Yeah, as we touched on, gene expression profiling has indeed identified those DLBCL subtypes with different prognosis. The GCB-like and ABC-like subtypes, with GCD-like DLBCL, consistently associated with significantly better overall survival. To make this information more readily accessible in the clinic without needing the full gene array, a practical immunohistochemical algorithm has been developed. It correlates pretty closely with those gene expression profiles, using specific antibody stains on the biopsy stains for proteins like CD10, BCL6, and MUM1 to help differentiate GCB from non-GCB-like DLBCL.
But does it change treatment right now?
And crucially, while these profiles, whether from gene arrays or the IHC algorithm, have significant prognostic importance, they tell us who's likely to do better or worse with standard therapy. They do not currently alter primary treatment recommendations for DLBCL in standard clinical practice outside of a trial. However, this is rapidly evolving, as I mentioned. Clinical trials are increasingly stratifying patients based on these subtypes, recognizing that future treatments will likely be differentiated based on these genetic signatures. We're already seeing hints of this, like the BTK inhibitor ibrutinib, showing more activity in non-GCB DLBCL in the relapse setting. So it's definitely signaling the path toward truly individualized therapies down the road.
This deep dive really highlights how personalized medicine is becoming, or at least aiming to become. Now, let's transition into the clinical features, specific treatments, and prognosis for some of the key NHL subtypes we've mentioned. It sounds like we're about to navigate a very complex landscape here.
It truly is a complex landscape, yes, and it requires real precision in diagnosis and treatment. Broadly, the B-cell NHLs, which are the most common, can be categorized into 2 main groups based on behavior. First, those that are aggressive. Exactly. Fast-growing and requiring immediate, intensive combination chemotherapy. The good news is these are potentially curable. Key examples are diffuse large B-cell lymphoma, DLBCL, which we've talked about, and Burkitt's lymphoma. Burkitt's is arguably the most rapidly proliferating human neoplasm we know.
And the second group?
Second, we have the indolent lymphomas. These are slow-growing. They often can be observed, sometimes for years, and treatment is typically initiated only when they cause symptoms or start to impair organ function. While they're very responsive to therapy when it's given, they are generally not considered curable in most cases with current standard approaches.
Okay, examples.
Follicular lymphoma is the prime example here. It's the second most common NHL overall and the most common indolent type. Other indolent NHLs include marginal zone lymphoma, lymphoplasmacytic lymphoma, and hairy cell leukemia.
And you mentioned an intermediate category.
Right. Then there's mantle cell lymphoma, MCL. It sort of sits in an intermediate category. It often requires aggressive initial chemotherapy, similar to the aggressive lymphomas, but paradoxically, it's not readily curable with conventional therapies. It often behaves more like the indolent types in its long-term relapsing course. It's a real challenge.
Okay, let's start with Burkitt's lymphoma, or BL. You mentioned its incredibly rapid growth. How does that actually manifest clinically, and what's its unique pathology and genetic signature?
Burkitt's lymphoma is indeed one of the fastest-growing human neoplasms known, with a potential tumor doubling time of less than 24 hours. It's incredible. While it's actually rare in adults in the United States, making up less than 1% of NHLs, it accounts for a significant portion, about 30% of childhood NHLs.
And how does it present?
There are three major clinical presentations seen globally. The endemic, or African form, often presents as a jaw or facial bone tumor, and it rapidly spreads to extranodal sites, ovaries, testes, kidneys, breast, bone marrow, and the meninges covering the brain and spinal cord. The non-endemic form, more common in Western countries, typically presents with massive abdominal disease, maybe ascites, fluid in the abdomen, and involvement of kidneys, testes, or ovaries. It's also prone to spreading to the bone marrow and central nervous system, the CNS.
And the third type?
Immunodeficiency-related cases often seen in HIV patients. These more commonly involve lymph nodes and can even present looking like an acute leukemia. BL predominantly affects males and is typically seen in patients younger than 35. Pathologically, on biopsy, BL shows this monotonous infiltration of medium-sized cells. They have a round nuclei, multiple nucleoli, and deeply basophilic cytoplasm that contains these characteristic lipid vacuoles. The proliferation rate is astonishingly high, often approaching 100%. You see mitotic figures everywhere.
And the starry sky.
Ah yes, the classic starry sky appearance seen under the microscope. That's due to scattered reactive macrophages, which have pale cytoplasm because they're engulfing dead tumor cells, set against the background of the densely packed dark blue tumor cells. Immunophenotypically, the tumor cells are consistently positive for B-cell antigens CD19 and CD20, surface immunoglobulins CD10 and BCL6. Critically, they are negative for BCL2, which helps distinguish them from some types of DLBCL.
What about EBV and genetics?
Endemic BLs are typically Epstein-Barr virus positive, while most non-endemic BLs are EBV negative. Genetically, over 95% of BL cases are defined by that specific translocation involving the MYC oncogene on chromosome AQ24. The most common partner is chromosome 14, fusing MYC to the IGH gene, but it can also involve chromosome 2, kappa light chain, or 22 lambda light chain. That MYC translocation is really the defining genetic event.
Given its blistering growth rate, treatment for Burkitt's must be incredibly urgent and very aggressive, right?
It is absolutely imperative. Treatment for BL must be initiated quickly, often within hours of diagnosis, because of that rapid doubling time and the high potential for life-threatening complications like tumor lysis syndrome. While it's exquisitely sensitive to chemotherapy, prompt and correct treatment is absolutely the key to cure.
What kind of chemo?
Several highly intensive multi-agent combination chemotherapy regimens are used. They all incorporate high doses of cyclophosphamide and other agents that cross the blood-brain barrier. And mandatory prophylactic therapy to the central nervous system is also required, given its high predilection for CNS involvement.
What's the cure rate like?
When treated appropriately and promptly, cure can be expected in a remarkable 80 to 90% of patients, even with widespread disease. Regimens like dose-adjusted EPO-CHR, which combines rituximab with an infused regimen of etoposide, vincristine, doxorubicin, cyclophosphamide, and prednisone, are highly effective. However, it's absolutely crucial to note that salvage therapy for relapsed BL has generally been ineffective. This just highlights the immense importance of getting the initial treatment approach exactly right, and ideally referring these patients to tertiary cancer centers experienced in managing this aggressive, yet highly curable disease. There's really only one shot at cure.
That brings us to diffuse large B-cell lymphoma, or DLBCL, which you mentioned is the most common NHL overall. What are its defining characteristics, and how does it typically present in patients?
Right. DLBCL represents about 1/3 of all NHL cases worldwide. And while it was once thought of as a single disease, we now recognize it as a very heterogeneous collection of multiple distinct entities. It's slightly more common in Caucasians and in men, with a median age at diagnosis around 64, though it can occur at any age.
Any known risk factors?
Risk factors include a slightly higher relative risk among first-degree relatives, also congenital or acquired immunodeficiencies, immunosuppression post-transplant, and certain autoimmune disorders. Often these are related to underlying EBV infection in those settings.
How does it usually show up?
The majority of patients, maybe 60-70%, present with advanced stage disease, meaning stage 3 or 4 VOI. It is spread beyond a localized area. And about 40% will have those classic B symptoms we discussed: fever, night sweats, weight loss. Elevated LDH levels, indicating higher tumor burden or rapid turnover, are also seen in about half of patients at diagnosis.
Can it affect organs outside lymph nodes?
Yes, absolutely. Up to 40% will have involvement of non-lymph node sites, what we call extranodal involvement. This can include the bone marrow, the central nervous system, the gastrointestinal tract, thyroid, liver, skin, testes, many potential sites. And patients with extensive bone marrow involvement or involvement of certain high-risk sites, like the testes, breast, kidney, adrenal gland, paranasal sinuses, or the epidural space, are at increased risk of CNS dissemination and require special consideration for CNS prophylaxis during treatment.
So it's often widespread at diagnosis and can affect many different organs. What does its pathology tell us about its diverse nature? We touched on GCB and ABC types earlier.
Exactly. The tumor itself consists of a diffuse proliferation, meaning it wipes out the normal lymph node structure of large atypical lymphocytes. They have a high proliferative index, meaning they are rapidly dividing. These cells typically express the pan-B-cell antigens CD19, CD20, and CD79A. As we discussed, their gene expression patterns allow for that critical classification into subtypes based on their presumed cell of origin. GCB-like, germinal center B-cell origin, which typically express CD10 and/or BCL6, and ABC-like, activated peripheral blood B-cell origin, which are usually CD10 negative and express MUM1.
What about other key proteins like BCL2 and MYC?
BCL2, the anti-apoptosis protein, is overexpressed in a significant proportion, maybe 25-80% of DLBCLs, depending on the study and subtype. BCL6 is positive in over 2/3 of cases. And MYC, that potent oncogene, is rearranged in about 10% of DLBCLs.
And what's the profound significance of that MYC rearrangement? I think you mentioned double-hit lymphoma, and it sounds pretty ominous.
Yes. This is a really critical point for prognosis, unfortunately. About 20% of those MYC rearranged DLBCL cases also have concurrent rearrangements of either BCL2 or BCL6. This specific combination is what's referred to as double-hit lymphoma, or sometimes triple-hit if all three are rearranged. And it carries an extremely poor prognosis, with a median overall survival historically of only about 12 to 18 months, even with aggressive therapy.
Wow.
Even amplification or just overexpression of the MYC protein without the specific rearrangements is also associated with a poor, albeit perhaps slightly better prognosis than the double hits. These genetic alterations are powerful drivers of aggressive disease and often dictate the need for more intensive treatment strategies.
So the genetics truly drive the prognosis there, offering a sometimes harsh glimpse into the future. What's the standard treatment for DLBCL nowadays, and what are the overall chances of cure?
Combination chemotherapy offers potentially curative therapy for DLBCL, regardless of the stage. The standard first-line treatment, which really represented a major advance over older regimens, is RCHOP. That regimen adds the anti-CD20 monoclonal antibody rituximab to a well-established backbone of chemotherapy: cyclophosphamide, hydroxydoxorubicin, oncovin, vincristine, and prednisone. RCHOP significantly improved survival compared to CHOP alone and became the global standard.
How is it used for different stages?
For early-stage disease, like stage I or II, that's localized perhaps to a radiation field, treatment options typically include either a full course of RCHOP for 6 cycles, or maybe an abbreviated course of 3 to 4 cycles, followed by involved field radiotherapy to the affected area. For advanced stage DLBCL, stage 3 or 4, a full course of RCHOP chemotherapy, usually 6 cycles, is administered.
And the cure rate?
On average, with RCHOP-based therapy, about 60-65% of patients with DLBCL can expect to be cured. The likelihood of cure for an individual patient is strongly predicted by their IPI score, their gene expression profile cell of origin, GCB versus ABC, and the presence or absence of those critical MYC cytogenetics and overexpression.
Are there alternative regimens for specific situations?
Yes. Alternative, sometimes more intensive regimens, like dose-adjusted REPOCH, are often used for specific aggressive subtypes like primary mediastinal large B-cell lymphoma and for those very high-risk double-hit DLBCLs, trying to improve outcomes. And as we mentioned, CNS prophylaxis, either with chemotherapy injected into the spinal fluid, intrathecal, or high doses of intravenous methotrexate, is crucial for those high-risk patients to prevent a lymphoma from spreading to the brain or spinal cord.
What about those patients, that remaining third or so, who don't respond to initial therapy or experience a relapse later? What are the options then, particularly thinking about some of the new, innovative therapies that seem to be truly transforming outcomes?
Yeah, that's a critical group. Over one-third of patients will either have primary refractory disease, meaning it doesn't respond adequately to the first-line therapy, or they'll experience a relapse after achieving an initial remission. While these cases are certainly challenging, patients may still be cured sometimes with intensive salvage chemotherapy regimens. If they show sensitivity to the salvage chemo, then consolidating that response with high-dose chemotherapy followed by autologous stem cell transplantation can significantly improve response duration and survival, leading to long-term disease-free survival in maybe 40–50% of those patients with chemosensitive relapse.
What if they aren't candidates for transplants or the chemo doesn't work?
For patients who are not candidates for such aggressive therapy, due to poor performance status, advanced age, or other comorbidities, palliative care is often employed. This might involve local radiation for symptom control or less intensive chemotherapy regimens just to manage the disease. However, for those with truly chemorefractory disease, meaning the lymphoma hasn't responded even to intensive prior chemotherapy regimens, chimeric antigen receptor T cells, or CAR T cells, offer a truly groundbreaking and potentially curative option. This is revolutionary.
Explain CAR T again briefly. How does it work?
It's a form of immunotherapy. T cells are collected from the patient's own blood. Then they're genetically modified in a specialized lab to express a receptor, the SAHAR, that specifically targets a protein found on the surface of most B-cell lymphoma cells, typically CD19. These engineered CAR T cells are then grown up to large numbers and infused back into the patient.
And they act like living drugs.
Exactly. They act like living drugs, actively seeking out and destroying the lymphoma cells that express CD19. This has shown remarkable response rates in heavily pretreated patients. Overall response rates over 80%, with more than 50% of patients achieving a complete response. And encouragingly, these responses appear to be durable in a significant fraction, with maybe 40% of patients remaining in remission at long-term follow-up.
That's incredible for patients with few options.
Absolutely transformative. CAR T cells are now approved for relapsed refractory DLBCL after 2 or more prior lines of systemic therapy, including for patients who relapse after an autologous stem cell transplant. Think about the profound impact this has on patients who, just a few years ago, really had no other effective options. This isn't just a scientific breakthrough, it's a genuine lifeline.
That's incredibly powerful, leveraging the patient's own immune system like that. Are there other targeted therapies emerging for relapsed DLBCL that might be less intense but still highly effective?
Yes, the field is moving rapidly. There are several other exciting targeted therapies. Targeting CD19 with a monoclonal antibody called tafasitamab, used in combination with lenalidomide, has also shown high response rates and prolonged durability, leading to its recent approval in certain settings.
What else?
Bispecific antibodies are showing great promise. These cleverly engineered antibodies target both CD20 on the malignant B cells and CD3 on the patient's own T cells. This effectively brings the T cells right next to the lymphoma cells, activating the T cells to specifically attack the lymphoma. Several are in late-stage development or recently approved. Polatuzumab vedotin is another approach. It's an antibody-drug conjugate. It combines an antibody targeting CD70MBB, another B-cell protein, with a potent chemotherapy toxin, delivering the payload directly to the cancer cells. It's approved, often in combination with chemo and rituximab, for relapsed refractory DLBCL. And selinexor, an oral selective inhibitor of nuclear export, or SINE, has demonstrated modest activity as a single agent in very refractory cases.
Are these cures or more like bridges?
That's a good question. While these newer agents are exciting and offer significant hope and can induce remissions, they're generally viewed, perhaps outside authority in some cases, as providing disease control, or maybe acting as a bridge to something more definitive like an allogeneic stem cell transplant for eligible patients, as they are perhaps less likely to lead to durable permanent remissions on their own compared to CAR-T or allo-SCT.
Okay. And you mentioned other specific large B-cell lymphoma types briefly.
Right. We also categorize other rarer large B-cell lymphomas, such as intravascular lymphoma, T-cell histiocyte-rich large B-cell lymphoma, EBV-positive DLBCL of the elderly, and ALK-positive large B-cell lymphoma. For most of these, RCHOP or similar regimens remain the primary treatment approach, though prognosis can vary widely. For example, EBV-positive DLBCL of the elderly and ALK-positive large B-cell lymphoma, unless it's treated with specific ALK inhibitors, generally carry poor outcomes.
Okay, now let's turn to follicular lymphoma, or FL. You call this the most common indolent NHL. What defines this type, and how does its indolent or slow-growing nature affect the general approach to treatment?
Right. Follicular lymphomas are the second most common NHL diagnosis overall, making up about 22% of NHLs worldwide, and perhaps even more, maybe 30% in the U.S. It's definitely the most common indolent NHL. Diagnosis is made by an expert hematopathologist who identifies a distinctive follicular or nodular growth pattern in the lymph node biopsy. These follicles are composed of malignant B cells, specifically small cleaved cells called centrocytes, and larger cells called centroblasts, in varying proportions.
What about its ID badge, the immunophenotype?
Immunophenotypically, FL cells are typically positive for B cell markers like CD19, CD20, CD10, and BCL6. Importantly, they're generally negative for CD5 and CD23, which helps distinguish them from some other lymphomas like CLL or mantle cell. Genetically, over 85% of FLs harbor that hallmark T1418 translocation, leading to overexpression of the anti-apoptotic BCL2 protein.
But that translocation isn't enough on its own.
Correct. While this genetic event seems necessary, it's clearly not sufficient for malignant transformation. We now know that multiple additional genetic events, often mutations in genes that modify the epigenome genes like MLO2, EZH2, CREBBP, and EP300, are required for FL to fully develop. It's a multi-step process.
How is FL graded? Does that specific grading impact the treatment strategy?
Yes, FL is graded pathologically by the WHO classification from grade 1 to grade 3, based on the number of those large cells, the centroblasts, seen per high-power field in the biopsy. Grade 1 and 2 have fewer centroblasts, while grade 3 has more.
Is grade 3 uniform?
Within grade 3, there's a further important distinction. Grade 3A still contains a mixture of small cleaved cells, centrocytes, and centroblasts, while grade 3B consists predominantly, almost entirely, of sheets of centroblasts. This distinction, although sometimes challenging for pathologists to make reproducibly, has critical prognostic and therapeutic significance. Patients with FL that have predominantly large cells tend to progress more rapidly and have a shorter overall survival with simple chemotherapy. Crucially, grade 3 BFL is considered biologically and clinically more like an aggressive lymphoma, similar to DLBCL, and is therefore treated as such with curative intent, unlike its more indolent grade 1, 2, or 3A counterparts.
So FL is often asymptomatic, can hang around for a long time, but carries that risk of transforming to a more aggressive form. How is it typically managed day to day, given its usually indolent nature at the start?
The most common presentation for FL is usually new, painless lymphadenopathy, swollen glands, often involving multiple lymphoid sites throughout the body. Unlike aggressive lymphomas, most patients typically do not have elevated LDH, or those classic B symptoms at diagnosis. However, a significant long-term concern is that histologic transformation to DLBCL, which occurs at a rate of about 3% per year cumulative risk. This transformation can be heralded by rapid lymph node growth, new B symptoms, or rising LDH.
How is prognosis assessed?
Prognosis for FL is best predicted by the FLAPI score we mentioned earlier. Staging is typically done with CT scans, though PCT scans can be helpful, particularly if transformation is suspected. It would show much higher FDG uptake. Or sometimes to confirm truly localized early-stage disease if potentially curative local therapy like radiation is being considered.
And for treatment, because it's indolent, is observation or watch and wait a common approach even for confirmed cases?
Yes, very much so. This is really a core tenet for managing most indolent lymphomas, including FL. Although FL is highly sensitive to both chemotherapy and radiotherapy, these therapies are usually not ultimately curative for widespread disease. The exception is truly localized early-stage disease.
Stage I or maybe 2?
Exactly. If the disease can be entirely encompassed within a single radiation field, involve field radiotherapy at a dose of around 24-30. Chigay can indeed be curative, with long-term freedom from treatment failure rates reported as high as 72% in some studies. However, For the majority of patients who present with more widespread asymptomatic disease, careful observation, often called watch and wait or active surveillance, is a perfectly reasonable and often preferred alternative to immediate treatment.
Why wait?
Numerous large studies have consistently shown that initiating treatment for asymptomatic low-burden FL does not improve overall survival compared to a program of close observation, where treatment is reserved only for when the disease causes symptoms, progresses significantly, threatens organ function, or the patient simply prefers treatment. So yes, asymptomatic patients are generally observed until treatment becomes necessary.
When treatment is indicated, maybe due to symptoms or high tumor burden, what are the primary options, ranging from single agents maybe, up to combination therapies?
When treatment is indicated, the decisions are often guided by the volume of disease, the pace of growth, the symptoms, and patient factors like age and comorbidities. For low-volume disease, or maybe just for inflammatory or autoimmune phenomena driven by the FL, single-agent rituximab, that anti-CD20 monoclonal antibody, is a very common and effective choice. It's associated with about a 70% overall response rate and a median response duration of maybe 18 months or so. Maintenance rituximab given periodically after the initial induction therapy can further improve the duration of that response.
What about for more extensive disease?
For patients with a larger volume of disease, more widespread involvement, or more significant symptoms, combining rituximab with chemotherapy regimens like CHOP or CVP, cyclophosphamide, vincristine, prednisone, basically CHOP without the doxorubicin, has demonstrably improved response rates and survival compared to chemo alone. More recently, bendamustine plus rituximab, or BR, has emerged as a very common, arguably standard, first-line therapy for medium to high-volume FL. It often offers longer response durations and potentially less toxicity, particularly less hair loss and neuropathy compared to RCHOP. Maintenance rituximab after BR also significantly improves outcomes. A newer second-generation anti-CD20 antibody, obinutuzumab, used in combination with chemotherapy, is also an approved option for untreated FL, potentially offering slightly better progression-free survival than rituximab combinations in some analyses.
Given its indolent but relapsing nature, does FL almost always recur eventually? And what are the strategies for managing relapse disease, particularly with all the new targeted agents coming online?
Unfortunately, yes. Despite high initial response rates, FL almost always recurs after therapy for patients with advanced stage disease. So it's often managed as a chronic condition over many years, with periods of remission followed by relapse requiring further treatment, where treatment is again generally reserved for symptomatic disease.
What are the options upon relapse?
Many of the same first-line regimens can be effective again, especially if the remission was long. Both autologous and, more rarely, allogeneic hematopoietic stem cell transplantations can yield high complete response rates in relapsed FL, potentially leading to long-term remissions in about 40% and maybe up to 60% of selected patients, respectively. However, allogeneic SCT carries significant risks and is usually reserved for younger, fit patients with multiply relapsed FL that's no longer responsive to conventional chemotherapy.
And the targeted agents.
This is where things are getting really exciting. More targeted oral therapies are making a significant impact in relapsed FL. These include lenalidomide, an immunomodulatory drug, often used with rituximab. Various PI3 kinase inhibitors like idelalisib, duvelisib, and copanlisib are approved, though they have specific toxicity profiles that need careful management. And EZH2 inhibitors like tazemetostat are approved specifically for patients whose tumors have an EZH2 mutation, or for those without mutations who have no other satisfactory options.
What about CAR-AT for follicular?
Critically, yes. Anti-CD19 CAR T-cell therapies are also approved now for relapsed refractory FL after 2 or more lines of therapy. They're showing impressive complete responses in over 80% of patients in trials, and many of these responses appear quite durable, potentially offering a curative option for a subset of these heavily pretreated patients, although longer follow-up is still needed to really define their definitive role in long-term outcomes compared to other options.
So despite being generally non-curative in the advanced stages, the long-term outlook for FL patients seems to be actually improving significantly overall.
Yes, this is a very positive trend and a key message. Most patients diagnosed with FL today can expect to live for 15-20 years or even longer. This survival has dramatically improved over the past few decades, largely due to our improved understanding of its biology, the introduction of rituximab, better supportive care, and the growing number of effective therapies available for relapsed disease. However, it's important to note that patients who present with a high-risk FLAPI score, those who don't achieve a complete metabolic response on a PTT scan after primary therapy, and especially those who relapse within 2 years of completing their initial primary chemotherapy, known as POD24, tend to have significantly poorer outcomes. These factors help identify patients who might benefit from alternative or more intensive strategies, perhaps earlier consideration of novel agents or transplants.
And that transformation to DLBCL you mentioned, that critical complication, how is that specifically managed when it happens?
Right. Histologic transformation to DLBCL is a major concern, occurring in about 3% of FL patients per year cumulative risk. It's often recognized clinically by rapid lymph node growth, the development of new or worsening systemic B symptoms, or a sharp rise in LDH. If this transformation occurs in a patient with previously untreated FL, then standard RCHOP chemotherapy, the treatment for de novo DLBCL, can potentially be curative for the aggressive component, although the underlying indolent FL might eventually recur later.
What if they've already had treatment for FL?
If transformation occurs in previously treated FL, the prognosis is generally poor. Aggressive combination chemotherapy is still used, but it should ideally be consolidated with an autologous stem cell transplant if the patient is eligible and achieves a good response to the salvage therapy. And just to reiterate, grade 3B FL, because it's biologically similar to DLBCL, is treated upfront as DLBCL with curative intent from the outset.
Okay, let's move on to marginal zone lymphoma, or MZL. How does this fit into the picture of indolent B-cell NHLs, and what are its key subtypes?
Marginal zone lymphoma is the second most common type of indolent B-cell NHL after follicular, comprising maybe 5–10% of all NHLs. It actually has 3 main subtypes, based primarily on where it arises. There's splenic MZL, which involves the spleen, blood, and bone marrow. There's extranodal MZL of MALT, type MALT, standing for mucosa-associated lymphoid tissue, which arises outside of lymph nodes in places like the stomach, eyes, lungs, or skin. And then there's nodal MZL, which primarily involves the lymph nodes themselves.
Let's start with nodal MZL. How does that compare to follicular?
Nodal MZL typically involves lymph nodes, with a distinctive pattern of infiltration by atypical lymphocytes, often with sort of monocytoid features, meaning they resemble monocytes. They tend to cluster in the parafollicular or paravascular areas. Immunophenotypically, these cells are positive for B-cell markers CD19, CD20, and CD79A, but are largely negative for CD10 and often CD5, helping distinguish them from FL or MCL. Some cases show plasmacytoid differentiation, which can lead to monoclonal immunoglobulin spikes in the blood. Treatment for nodal MZL often mirrors that of follicular lymphoma observation for asymptomatic disease, rituximab or chemoimmunotherapy for symptomatic disease. One notable exception is that the BTK inhibitor ibrutinib seems to be highly active in relapsed nodal MZL, perhaps more so than in FL.
What about splenic MZL? You mentioned a connection to hepatitis C.
Yes. Splenic MZL is predominantly a disease of older Caucasian patients, and interestingly, chronic hepatitis C virus infection is a recognized risk factor. A fascinating aspect here is that treating the underlying hepatitis C infection with direct-acting antivirals can, in some cases, actually lead to regression of the lymphoma itself, presumably by removing the chronic antigenic stimulus.
How does it usually present?
Patients typically present with lymphocytosis, high lymphocyte count in the blood, cytopenias, low counts of other blood cells, and splenomegaly, a large spleen. Bone marrow involvement is common. Diagnosis can often be made by flow cytometry of the peripheral blood, which shows malignant lymphocytes positive for a surface immunoglobulin, CD19 and CD20, but generally lacking CD5 and CD10. On a peripheral blood smear, these cells can have small nuclei and abundant cytoplasm with characteristic shaggy or villous projections. It needs to be carefully distinguished from hairy cell leukemia, which it can resemble, by the absence of markers like CD25, CD103, and annexin A1. Recurrent genetic abnormalities in splenic MZL include trisomy 3 and abnormalities of chromosome 7q.
And how is splenic MZL typically treated? Is splenectomy still common?
Therapy for splenic MZL is indicated when the disease causes symptoms, significant cytopenias, or massive splenomegaly. Splenectomy, the surgical removal of the spleen, used to be standard and can still be a very reasonable option for selected patients. It provides excellent relief of symptoms and cytopenias with high overall response rates, around 85%, and good long-term progression-free and overall survival rates. However, single-agent rituximab is also highly effective, leading to significant improvement in splenomegaly and cytopenias in over 90% of patients, often making surgery unnecessary. Long-term survival rates for splenic MZL are generally excellent, typically exceeding 70% at 10 years.
Okay, now you mentioned extranodal MZL of MALT type, which brings us back to that really compelling Helicobacter pylori connection in the stomach.
Yes. MALT lymphoma is a fascinating type of MZL that arises in extranodal tissues, most commonly the stomach, and is powerfully driven by chronic inflammation. but it can occur in many other sites: the skin, salivary glands, lung, small bowel, ocular adnexa around the eye, breasts, bladder, thyroid, dura, linings of the brain, even synovium, joint lining. Its etiology is strongly associated with chronic inflammation, either from autoimmune diseases like Sjogren's syndrome, salivary glands, or Hashimoto's thyroiditis, thyroid, or from chronic infections.
And H. pylori is the classic example.
Exactly. H. pylori in the stomach is a classic example. But others include Borrelia burgdorferi, causing Lyme disease, linked to skin malt lymphomas in Europe, Palmitobophila fetachi, linked to conjunctival malt lymphomas, Campylobacter jejuni, linked to intestinal malt lymphomas, and chronic hepatitis C virus infection has also been implicated.
So it's really that persistent chronic irritation or antigenic stimulation that's driving the problem in these tissues. What about its specific pathology and genetics?
The essential pathologic feature of malt lymphoma is the presence of distinctive lymphoepithelial lesions. This is where the neoplastic lymphocytes actually invade the normal mucosal glands and crypts of the tissue. Immunophenotypically, these cells are positive for B-cell markers CD19, CD20, and CD79A, and usually negative for CD5 and CD10. Genetically, recurrent cytogenetic abnormalities are common, including the T1118 translocation, which is the most frequent, occurring in up to 50% of cases, particularly those arising outside the stomach. This translocation fuses the API2 gene and the MALT1 gene, leading to activation of the NF pathway, promoting cell survival. Other abnormalities include T1418 involving BCL2 like in follicular, but a different partner gene T114T314 and trisomy 3 or 18. Unlike many other indolent B-cell lymphomas, malt lymphoma is most commonly present with localized stage I or II disease. So for malt lymphoma, that localized presentation might actually mean it's curable with less aggressive interventions. Precisely. That's a key point. For localized malt lymphomas, especially stage I or IEE for extranodal, radiation therapy can indeed be curative, often with relatively low doses. Alternatively, and quite remarkably, for those associated with infection, such as gastric malt lymphoma linked to H. pylori, patients may respond completely simply to antibiotics that eradicate the underlying infection. Seeing the lymphoma melt away with just antibiotics is really a paradigm of targeted therapy based on etiology. For relapsed, refractory, or more advanced stage malt lymphoma, treatment approaches become similar to those used in follicular lymphoma, potentially utilizing rituximab, chemotherapy, or chemoimmunotherapy.
Okay, let's discuss lymphoplasmacytic lymphoma, or LPL, which you mentioned is often intimately associated with Waldenstrom's macroglobulinemia.
Right. Lymphoplasmacytic lymphoma, LPL, makes up only about 1% of all NHLs. It's an indolent B-cell NHL characterized by lymphoplasmacytic differentiation, meaning the malignant cells have features resembling both small lymphocytes and more mature plasma cells. Most commonly, almost definitionally, it's associated with the presence of a monoclonal IgM paraprotein in the blood.
And that IgM is key for Waldenstrom's.
Exactly. Patients with LPL who have high levels of this circulating IgM leading to symptoms constitute a specific clinical entity known as Waldenstrom's macroglobulinemia. Their symptoms can be directly due to hyperviscosity, thick blood caused by the high levels of circulating IgM protein, or sometimes due to perineoplastic effects like peripheral neuropathy. Nearly all patients with LPL will have stage IV disease with bone marrow involvement at the time of diagnosis.
And what's the key genetic driver here that's been identified in recent years?
A really critical genetic feature of LPL, discovered relatively recently, is the presence of activating mutations in a gene called MYD88, specifically the L265 key mutation. This is found in over 90% of cases of LPL Waldenstrom's. This mutation leads to chronic activation of the NFT pathway, which powerfully contributes to the growth and survival of lymphoma cells. Pathologically, bone marrow biopsies show this proliferation of small lymphocytes, lymphoplasmacytic cells, and plasma cells. The malignant lymphocytes are positive for B-cell markers CD19, CD20, and surface IgM, but generally negative for CD5 and CD10.
How is LPL treated, especially when those complications like hyperviscosity are present?
As with other indolent NHLs, treatment for LPL is generally indicated only when the disease causes significant symptoms or interferes with organ function. Specific indications include symptomatic hyperviscosity, significant anemia or other cytopenias, bulky disease, or debilitating perineoplastic neuropathy. Single-agent rituximab can be useful for lower volume disease, although it can sometimes cause a transient flare or rise in serum IgM that might actually exacerbate hyperviscosity initially, so it requires careful monitoring or might be combined with plasmapheresis.
What about chemo or targeted therapy?
Chemoimmunotherapy regimens, such as bendamustine plus rituximab, BR, or rituximab, cyclophosphamide, and dexamethasone, are highly active. Certain myeloma therapies, like the proteasome inhibitor bortezomib, can also be effective. Critically, the BTK inhibitor ibrutinib, often in combination with rituximab, is highly active for both previously untreated and relapsed LPL Waldenström's, leveraging that MYD88 pathway activation.
And the hyperviscosity itself.
For acute relief of hyperviscosity symptoms, plasmapheresis filtering the IgM protein out of the blood plasma is very effective and works quickly because about 85% of IgM remains within the intravascular space. For refractory LPL, other options include the mTOR inhibitor everolimus. Selected younger patients with relapsed disease might also be considered for high-dose therapy with autologous or allogeneic stem cell transplantation, with results generally similar to those seen in other indolent lymphomas.
Okay, next up is mantle cell lymphoma, or MCL. You mentioned earlier it sits in this kind of intermediate category, which seems to imply a unique challenge. What makes MCL so unique and often complex to manage?
Mantle cell lymphoma accounts for about 6% of NHLs. It's considered intermediate grade or sometimes clinically aggressive but biologically distinct because, like the indolent B-cell NHLs, it's generally not considered curable with conventional chemotherapy regimens, even intensive ones. However, unlike most indolent lymphomas, it often requires more aggressive initial chemoimmunotherapy regimens, sometimes even consolidation with an autologous stem cell transplant in first remission, just to achieve a reasonable duration of response. But despite these aggressive upfront treatments, it typically relapses, and the median survival has historically been in the order of 5 to 10 years, though this is improving. So it presents a significant management challenge, aggressive treatment needed, but cure remains elusive for most with standard therapy.
Are there different variants of MCL with different prognoses, almost like different personalities of the same disease?
Yes, absolutely. This is increasingly recognized and important. There's a subset, maybe 10-15%, considered a more indolent variant. This is often characterized by being SOX11 negative. SOX11 is a transcription factor, often presenting with circulating disease, leukemic phase, and splenomegaly, but without significant lymphadenopathy. And importantly, having a low proliferative index, or Ki67, usually less than 10%. This subset can sometimes behave much more like indolent B-cell NHLs and can frequently be observed using a watch-and-wait approach until symptoms necessitate treatment.
And the other end of the spectrum.
On the other end is a blastic variant, which looks morphologically more immature and aggressive and typically has a very high Ki67 index. This is associated with a particularly poor prognosis, with a median overall survival historically of only about 18 months. For the majority of patients who fall between these extremes, prognosis is best predicted by the biologic MCL International Prognostic Index, or MIPIB. This incorporates clinical factors like age, performance status, LDH, and white blood cell count, along with the Ki67 proliferative index from the biopsy. Furthermore, MCLs that harbor a TP53 mutation or have a complex karyotype, multiple chromosomal abnormalities, are considered particularly high risk, signaling an even more aggressive course and often resistance to standard chemo.
What's the typical clinical presentation for most MCL patients, and what's its definitive genetic fingerprint that pathologists look for?
MCL is more common in men, with an average age of diagnosis around 63. Over 2/3 of patients will present with advanced stage IV disease at diagnosis, most commonly with bone marrow and peripheral blood involvement. A common extranodal site is the gastrointestinal tract, where it can cause diffuse lymphomatous polyposis like multiple small polyps throughout the colon or small bowel seen on endoscopy.
And the genetics?
The definitive genetic signature, the pathognomonic cytogenetic finding in MCL, is the T1114 translocation. This specific translocation brings the gene for the cell cycle control protein cyclin D1, CCND1, on chromosome 11, under the direct control of the powerful immunoglobulin heavy chain gene promoter on chromosome 14. This leads to massive overexpression of cyclin D1 protein in over 90% of cases, driving uncontrolled cell division through the G1S checkpoint. The remaining cases usually overexpress other related cyclins like D2, D3, or E through different mechanisms. Immunophenotypically, the tumor cells are positive for B-cell markers CD19 and CD20, and characteristically positive for CD5, like CLL-SLL, but they typically lack CD10, unlike FLL, and CD23, unlike CLS-LL. That CD5 plus ET23 pattern is key.
Given that it's generally not considered curable with conventional therapies, how is MCL typically treated now, aiming to maximize response duration and improve patient outcomes? The approach seems to be evolving.
It is definitely evolving. Therapies for MCL are constantly being refined, reflecting the ongoing challenge of this disease. True localized disease is exceedingly rare. The indolent variant, as we discussed, can often be observed initially. For the usual presentation with disseminated symptomatic disease, standard lymphoma treatments like RCHOP have historically yielded unsatisfactory results with short remissions.
So it's better.
More intensive induction regimens, often incorporating high-dose cytarabine, also known as Ara-C, have significantly improved progression-free survival, especially in younger, fitter patients. Examples include the Nordic regimens or R-Hyper-CVAD alternating with RMA. These are often, though not always, consolidated with an autologous stem cell transplantation in first remission for eligible patients. This intensive approach pushes the median remission duration out significantly, but still doesn't reliably cure the disease. Bendamustine plus rituximab BR is also highly active in MCL and is often considered a standard option, particularly for older or less fit patients, as it's generally better tolerated than the very intensive cytarabine-based regimens. Newer strategies are exploring ways to combine BR with cytarabine or other agents, again potentially followed by autologous stem cell transplant. Maintenance rituximab therapy, given for a year or two after achieving remission with induction chemotherapy or ASCT, also clearly improves outcomes and prolongs remission duration in MCL.
And for relapsed MCL, which sadly seems common, are there specific targeted therapies or even potentially curative options emerging that offer new hope?
Yes, this is where some of the biggest advances have occurred recently. For relapsed MCL, the covalent BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib, have shown significant single-agent activity, with overall response rates around 70%, although the median duration of response is typically around 18 months before resistance develops. These are now standard therapies for relapsed MCL and are being explored in combinations with other drugs like chemotherapy or the BCL2 antagonist venetoclax, trying to deepen responses and overcome resistance.
What about CAR-T for mantle cell?
Absolutely. The most significant potential advance for relapsed refractory MCL is CRT cell therapy, specifically targeting CD19. Brexacaptogene autoleucel is now approved for MCL patients who have progressed after prior lines of therapy, including a BTK inhibitor. In clinical trials, about 2/3 of these heavily pretreated patients achieve complete responses, and importantly, many of these responses appear durable through the limited follow-up available so far. This treatment is potentially the only curative therapy currently available for relapsed MCL outside of an allogeneic stem cell transplantation.
Are there other options?
Other agents like lenalidomide, often with rituximab, venetoclax, especially in combination, bortezomib, and temsirolimus can induce responses, but they are often partial and transient. For eligible younger patients who achieve a good response to salvage therapy, perhaps outside of LD cell therapy, allogeneic stem cell transplantation can still be considered. It offers the potential for long-term disease-free survival, maybe in 30–50% of patients who undergo it, but carries significant risks.
Okay, let's switch gears now to the less common but equally important mature T-cell lymphomas. What's the overall challenge with these lymphomas compared to the B-cell lymphomas we've just extensively covered?
Right. The mature T-cell disorders, which include cutaneous lymphomas like mycosis fungoides and the various peripheral T-cell lymphomas, or PTCLs, are significantly rarer overall than B-cell NHLs. They make up a much smaller fraction of the total NHL burden, maybe 10–15% globally. As a direct result of this rarity, our understanding of their fundamental biology is generally less advanced, and consequently our therapies are less well developed compared to the B-cell lymphomas where we have more targeted agents.
So the prognosis is often worse.
While some T-cell lymphomas, notably mycosis fungoides, can behave very indolently, and others, like ALK-positive anaplastic large cell lymphoma, can actually be cured with standard chemotherapy, the majority of PTCL subtypes are unfortunately associated with a poor prognosis. The good news is that the advent of genomic technologies is now critically enhancing our ability to understand their precise genetic and biological basis. This is absolutely essential for guiding future therapeutic advancements in this challenging area. We're starting to identify specific mutations and pathways that could be targeted.
Let's start with mycosis fungoides, which you mentioned is a type of cutaneous T-cell lymphoma. What are its unique clinical features and how does it typically progress over time?
Mycosis fungoides, sometimes abbreviated MF, or also just called cutaneous T-cell lymphoma, CTCL, is typically an indolent lymphoma that primarily manifests in the skin, so it's often managed initially by dermatologists. It typically affects individuals in their mid-50s and is somewhat more common in males and in individuals of Black descent.
How does it look?
Patients often experience several years, sometimes decades, of what looks like eczematous or dramatic skin lesions, maybe red, itchy patches, or slightly raised plaques, before the diagnosis is finally established. The diagnosis can be quite difficult in the early stages, sometimes requiring multiple biopsies over time. These skin lesions tend to progress predictably, though slowly, from a patch stage to a thicker plaque stage, and eventually may develop into elevated cutaneous tumors.
Can it spread beyond the skin?
In advanced stages, yes, the lymphoma can spread beyond the skin to involve lymph nodes, blood, and sometimes visceral organs. Some patients may develop generalized erythroderma, where the entire skin surface becomes red and scaly, and may have circulating tumor cells in the blood, a condition known as Sézary syndrome, which carries a worse prognosis than typical MF. Enlarged lymph nodes might reflect actual lymphoma involvement or just be reactive changes due to the chronic skin inflammation, dermatopathic lymphadenopathy.
How is mycosis fungoides treated, given its generally indolent nature and primary skin manifestations? Is cure possible?
For the rare patients who present with truly localized early-stage mycosis fungoides, cure can actually be achieved with radiotherapy, often using specialized techniques like total skin electron beam irradiation, which delivers radiation primarily just to the skin surface. However, for the majority with more widespread disease, treatments are generally palliative, aimed at managing symptoms like itching, improving the appearance of the skin lesions, and controlling disease progression rather than achieving a cure.
What kinds of palliative treatments are used?
There's a wide array of options, often used sequentially or in combination. These include topical therapies like potent glucocorticoids or topical nitrogen mustard, a type of chemotherapy applied to the skin. Phototherapy like psoralen with ultraviolet. A light, PUVA, is very common. Other options include extracorporeal photopheresis, where the patient's blood is treated outside the body with UV light, oral retinoids such as bexarotene, further electron beam radiation to specific areas, interferon injections, various targeted antibodies and fusion toxins, histone deacylase inhibitors like vorinostat or romidepsin, and brentuximab vedotin for cases that express CD30. More recently, mogamulizumab, an antibody targeting CCR4, has also shown significant activity and is approved for relapse-direct MF Sézary syndrome.
Okay. What about peripheral T-cell lymphoma, not otherwise specified, or PTCL and OS? That name itself sounds like a very broad and perhaps somewhat vague category.
It is indeed a broad and heterogeneous category, basically a diagnosis of exclusion. PTCL-NS accounts for about 6% of all NHLs globally and is essentially a collection of mature T-cell lymphomas that lack the specific features needed to classify them into other, more well-defined PTCL subgroups like AITL or ALCL.
Who does it typically affect?
It typically affects older individuals with a median age of presentation around 65. The majority of patients will have advanced stage disease at diagnosis, with common involvement of the bone marrow, liver, spleen, and sometimes the skin. Associated B symptoms and pruritus, that intense itching, are also common. These lymphomas can also sometimes be associated with reactive eosinophilia, high eosinophil count, and occasionally a severe systemic inflammatory condition called hemophagocytic syndrome.
What's the prognosis generally like?
While the standard IPI score has been applied to PTCL-NOS, it's clear that the prognosis is generally poor compared to aggressive B-cell lymphomas. Even patients falling into the low-risk IPI group unfortunately have a median overall survival of just over 2 years in many series, indicating the aggressive nature and therapeutic challenge of this disease group.
And what do we know about its pathology and genetics, given that it's defined by lacking specific features?
Exactly. Because it's a heterogeneous wastebasket category. The histology, immunophenotype, and genetics of PTCL-NS are highly variable. Lymph nodes are often effaced, meaning the normal structure is destroyed by atypical lymphoid cells of various sizes. Sometimes there's prominent vascular proliferation or a significant infiltrate of eosinophils and macrophages. Given their often aggressive behavior, mitotic figures, cells dividing, and apoptotic figures, cells dying, as well as areas of geographic necrosis are commonly observed.
What about the cell markers?
The tumor cells are typically positive for CD3, a pan-T-cell marker. Most PTCL-NOS cases are CD4 positive rather than CD8 positive, although some are negative for both CD4 and CD8, double negative. Loss of more mature T-cell markers like CD5 and CD7 is commonly seen and is often associated with more aggressive clinical course. There are some recurrent translocations described, often involving T-cell receptor genes on chromosome 14 or 7, but no single defining genetic abnormality like in many B-cell lymphomas.
What are the primary treatment approaches for PTCL-NS, given its often aggressive nature and generally poorer prognosis?
The most common primary therapy for PTCL-NS involves a CHOP-like chemotherapy backbone. Often CHOP itself, cyclophosphamide, doxorubicin, vincristine, prednisone, or sometimes CHAP combined with etoposide, known as CHOEP. The addition of etoposide and Chichokupi may offer the most benefit to younger patients, under 60, and perhaps those with more favorable disease risk factors, but it adds toxicity.
Any targeted agents used up front?
Brentuximab vedotin, the anti-CD30 antibody conjugate, has been studied upfront in combination with CHOP without vincristine, for patients with CD30-positive PTCLs, which can include some PTCL NUS cases. This combination, called BVCHP, showed improved progression-free survival compared to CHOP, particularly in patients with ALCL, leading to its approval in that setting. Autologous stem cell transplant in first remission has been investigated as a consolidation strategy for patients who achieve a response to induction chemo, and some studies suggest it might improve progression-free survival, though its role is still debated and likely depends on patient risk factors.
What about relapse?
For relapsed PTCL NOS, the options are limited and outcomes are generally poor. Drugs like gemcitabine, bendamustine, and palatrexate and antifolate show some activity. Histone deacetylase inhibitors like romidepsin and belinostat are approved and can induce responses, as can the PI3 kinase inhibitor duvelisib. However, responses to these agents are often transient and typically seen in a minority of patients. Therefore, enrollment in clinical trials exploring novel agents or combinations is often a crucial option for relapsed PTCL. For younger, fit patients who do achieve a remission with salvage therapy, reduced intensity allogeneic stem cell transplantation can offer the potential for more durable disease control, with long-term non-relapse survival rates reported around 40–50% in selected patients.
Okay. Let's move to angioimmunoblastic T-cell lymphoma, or AITL. What distinguishes this specific subtype, both clinically and pathologically?
AITL is one of the more common subtypes of PTCL, constituting about 20% of T-cell NHLs in some series, and maybe around 4% of all NHLs overall. Patients often present with a quite distinct constellation of systemic signs and symptoms. Most commonly, this includes generalized lymphadenopathy, swollen glands everywhere, hepatosplenomegaly, enlarged liver and spleen, prominent B symptoms, fever, sweats, weight loss, often a skin rash, sometimes polyarthritis, and frequently autoimmune phenomena like Coombs-positive hemolytic anemia.
So a very systemic illness.
Very systemic. Over 80% of patients have advanced stage disease at diagnosis, and bone marrow involvement is common. Laboratory findings often reflect this immune dysregulation. Polyclonal hypergammaglobulinemia, high levels of multiple types of antibodies, elevated LDH, eosinophilia, a positive Coombs test, and a propensity for opportunistic infections due to the underlying immune defect. Pathologically, on lymph node biopsy, the normal structure is effaced by a polymorphous infiltrate, meaning a mixture of cell types, including lymphocytes, immunoblasts, plasma cells, eosinophils, and histiocytes. Critically, the neoplastic T cells in AITL have a specific immunophenotype. They are positive for CD3 and usually CD4, but also express markers typically associated with follicular helper T cells, TFHLs, such as CXCL13, PD1, CD10, and BCL6. There's also a characteristic expansion of the follicular dendritic cell meshwork surrounding the tumor cells, and often prominent proliferation of small blood vessels. Scattered larger B-cell immunoblasts within the infiltrate are often EBV positive, and these can sometimes give rise to secondary EBV positive B-cell lymphomas later in the course of the disease.
What about genetics in AITL?
Recent genomic studies have revealed recurrent mutations in epigenetic modifier genes in AITL. The most common are mutations in PET2, found in about 76% of cases, DNMT3A in 33%, and IDH2, specifically the R172 mutation, in about 20%. These mutations likely contribute to the development of the disease by disrupting normal epigenetic regulation.
So how is AITL treated and what's its prognosis, which, again, often sounds quite challenging?
It is challenging. Interestingly, a small subset of AITL cases, particularly those presenting primarily with immune symptoms, can sometimes remit, paradoxically, with immunosuppressive therapy alone, using agents like glucocorticoids or methotrexate. However, most patients will require combination chemotherapy, typically similar to the regimens used in PTCL NOS, like ECHOP or CHOE. Unfortunately, even with chemotherapy, the median response duration is often short, and the median overall survival is typically only around 2.5 years, highlighting the aggressive nature and unmet need in this subtype. There's some emerging data suggesting activity for agents targeting those epigenetic mutations or pathways involved in TFH cell function, like BTK inhibitors or venetoclax, but these are still largely experimental.
Okay. Now, for anaplastic large cell lymphoma, or ALCL, this one stands out because you mentioned it has a more favorable prognosis in some cases, often linked to a specific genetic alteration, correct?
Yes, that's right. ALCL is the next most common T-cell lymphoma subtype after AITL and PTCL NOS. It's notably more common in children and young adults compared to other PTCLs, accounting for up to 10% of pediatric lymphomas. The critical distinguishing feature and the reason for the better prognosis in a subset is the presence or absence of a rearrangement involving the ALK gene, anaplastic lymphoma kinase, on chromosome 2.
How common is that ALK rearrangement?
About 40–60% of ALCL cases, particularly in younger patients, harbor a translocation, most commonly T25, which fuses part of the NPM1 gene on chromosome 5 to the ALK gene on chromosome 2. The resulting NPM1 ALK fusion protein has constitutive tyrosine kinase activity. It's permanently switched on, acting like a powerful growth signal driving the cancer. Importantly, ALK-positive ALCL has a much more favorable prognosis, remarkably similar to that of aggressive B-cell lymphomas like DLBCL, with reported 8-year overall survival rates around 82%. This contrasts sharply with ALK-negative ALCL, which has a much poorer prognosis, more akin to other PTCLs, with 8-year survival rates closer to 49%.
Are there other ALCL subtypes?
Yes. There are also more indolent favorable subtypes. One is primary cutaneous ALCL, which is confined to the skin and generally has an excellent prognosis, often managed with local therapies. Another distinct entity is breast implant-associated ALCL, BIA-ALCL, which typically presents as fluid collection or a mass around a textured breast implant, and also has a very favorable prognosis, often cured simply by removing the implant and the surrounding capsule.
Okay, focusing on the systemic type. What's the typical clinical presentation and treatment approach for ALCL?
Systemic ALCL is more common in men. As mentioned, ALK-positive disease tends to affect younger patients with a median age around 34, while ALK-negative patients are generally older, with a median age around 58. Most patients present with rapidly growing lymphadenopathy, often with extranodal involvement. Skin, bone, soft tissues are common sites, and B symptoms are frequent.
What does it look like under the microscope?
Pathologically, ALCL is characterized by the presence of large, atypical lymphocytes with distinctive horseshoe-shaped or kidney-shaped nuclei and prominent nucleoli. These are often referred to as hallmark cells. They typically infiltrate the lymph node sinuses in a cohesive pattern. Immunophenotypically, they are almost always strongly positive for CD30, but negative for CD15, which helps distinguish them from Hodgkin lymphoma. Most also express some T-cell markers like CD3, CD25, CD43, and CD4, although expression can sometimes be aberrant or lost. ALK-rearranged ALCL is diagnosed either by FUSH demonstrating the translocation or, more commonly, by immunohistochemical staining showing expression of the ALK protein.
How is systemic ALCL treated? Does ALK status matter?
ALCL is generally treated with CHP or CHOP-like chemotherapy regimens. CHOP, adding etoposide, may offer benefit to younger patients, especially those with ALK-positive disease. Given the importance of CD30 expression, the combination of brentuximab vedotin with CHP, EV-CHP, is now considered a standard frontline option for patients with CD30 plus PTCL, including both ALK plus and ALK-ALCL, based on trial data showing improved outcomes over CHOP.
What about relapse?
For relapsed ALK-positive ALCL, treatment approaches are often similar to those for relapsed DLBCL, potentially involving salvage combination chemotherapy, followed by autologous stem cell transplant for chemosensitive disease. For patients with chemotherapy-insensitive disease, or for relapsed ALK-negative disease, brentuximab vedotin is highly active as a single agent, achieving response rates of 86% with a 57% complete response rate in pivotal studies. Furthermore, for refractory ALK-positive ALCL, targeted ALK inhibitors, such as crisatinib or others, are very active and can yield excellent durable outcomes by directly inhibiting the abnormal ALK fusion protein.
We've covered a tremendous amount of ground on the major subtypes. Are there any other notable, though perhaps rarer, PTCL subtypes we should briefly touch on just to complete our mastery of this chapter?
Yes, absolutely. Briefly, there are a few other rare but distinct subtypes worth knowing about. Enteropathy-associated T-cell lymphoma, EATL, is a rare lymphoma arising in the small intestine. Type 1 is historically linked to a history of gluten-sensitive enteropathy, celiac disease, and specific HLA types. Remarkably, adhering to a strict gluten-free diet can actually help prevent its development in susceptible individuals. Type 2 is not associated with celiac disease. Patients are often severely malnourished or cachectic and can present with complications like intestinal perforation. Unfortunately, it carries a very poor prognosis, with a median survival of only about 10 months. Treatment typically involves intensive chemotherapy, sometimes including high-dose methotrexate, potentially followed by ACT in first remission if possible. Hepatosplenic gamma delta T-cell lymphoma is another rare and aggressive systemic illness characterized by infiltration of the sinusoids, the liver, spleen, and bone marrow by malignant gamma delta T cells, typically without forming discrete tumor masses. It's often difficult to diagnose, frequently affects young men, and has recurrent genetic features like isochromosome 7q. It carries a poor outcome, although regimens including ifosfamide, like ICE or IVC, have been associated with somewhat better results. Allogeneic SCT is often considered for responders. Subcutaneous paniculitis like T-cell lymphoma, SBTCL, is a rare lymphoma presenting as multiple subcutaneous nodules, often initially confused with benign paniculitis, inflammation of fat. It predominantly involves alpha-beta T cells and generally has a more indolent course, often managed initially with immunosuppression. A rarer gamma-delta variant exists, which is much more aggressive, often associated with hemophagocytic syndrome, and requires multi-agent chemotherapy, potentially followed by allogeneic SCT for responders.
Okay, very comprehensive. Finally, let's touch on adult T-cell leukemia lymphoma, or ATLL. What's its unique connection to the HTLV-1 virus, and what are its distinct features?
ATLL is a distinct clinical entity most prevalent in specific geographic regions, where the human T-cell lymphotropic virus type 1, HTLV-1, is endemic primarily southern Japan, the Caribbean Basin, parts of South America, and Central Africa. It's directly driven by chronic HTLV-1 infection, which is often contracted in infancy, commonly through breast milk from an infected mother. There's a remarkably long latency period, with the average age at diagnosis being around 60 years. Critically, only a small fraction, maybe 4%, of individuals chronically infected with HTLV-1 actually develop ATLL during their lifetime. This suggests that HTLV-1 infection alone isn't sufficient for malignant transformation, and other factors, possibly genetic or environmental, must also be at play.
Are there different forms of ATLL?
Yes, ATLL has 4 distinct clinical variants, which have very different prognosis. The acute variant is the most common, about 60%, and most aggressive, with a median overall survival historically of only around 6 months. The lymphomatous variant, 20%, also behaves aggressively, with median OS around 10 months. The chronic 15% and smoldering 5% variants are more indolent, with median survivals measured in years, although they can transform to the acute form.
What are the common clinical features?
Clinical presentations depend heavily on the subtype, but commonly include circulating malignant T cells in the blood, leukemia, bone marrow involvement, often hypercalcemia, high calcium levels, associated with lytic bone lesions, generalized lymphadenopathy, hepatosplenomegaly, various skin lesions, and a significant risk of opportunistic infections due to the profound T-cell immunodeficiency caused by the virus and lymphoma. Pathologically, the pathognomonic finding is the malignant flower cell, often seen in peripheral blood smears. These are T cells with highly convoluted, multi-lobed nuclei that resemble flower petals. Immunophenotypically, the malignant cells are mature T cells, typically positive for CD4 and CD25, the IL-2 receptor alpha chain, as well as CD2, CD3, and CD5, but characteristically lack CD7.
How is ATLL treated? It sounds very difficult.
It is very difficult, especially the acute and lymphomatous forms. Combination chemotherapy is generally used, but unfortunately response durations are typically very short. Other agents have shown activity, including the antiretroviral drug zidovudine, AZT, often combined with interferon alpha, particularly for leukemic subtypes. Arsenic trioxide has also shown some promise. For eligible patients, particularly younger ones who do achieve remission, allogeneic stem cell transplantation offers the only real potential for long-term cure or durable remission and should be strongly considered.
Okay, one last specific type mentioned. Extranodal NKT cell lymphoma, nasal type. What's notable about this one?
Right, extranodal NKT cell lymphoma, nasal type. This lymphoma is almost universally associated with Epstein-Barr virus, EBV infection, which seems to play a direct role in driving the malignancy. It's geographically more common in Asia and among native populations in Central and South America, like Peru.
Where does it typically occur?
As the name suggests, it usually presents with a destructive mass and obstructive symptoms in the upper aerodigestive tract, most commonly the nasal cavity, but also potentially the palate or nasopharynx. Occasionally, it can arise in other extranodal sites like the skin, GI tract, or testes. Over 2/3 of patients present with localized disease, stage 1 or 2. It's more common in men with a median age around 60.
How is prognosis determined?
Prognosis is related to several factors, sometimes incorporated into specific prognostic scores. These include the presence of B symptoms, disease stage, localized versus advanced, elevated LDH, regional lymph node involvement, and critically, the level of circulating EBV DNA viral load, both at diagnosis and particularly at the end of therapy. Persistent detectable EBV DNA after treatment is a very poor prognostic sign.
And the treatment approach?
For early stage localized disease, the standard approach is combined modality therapy. This usually involves chemotherapy regimens that specifically include drugs not affected by the P-glycoprotein efflux pump, which these tumors often express, making them resistant to drugs like doxorubicin found in CHOP. Regimens often contain drugs like adipocyte, ifosfamide, cisplatin, dexamethasone, or L-asparaginase. This is followed by involved field intensity-modulated radiation therapy, typically 50-55 JADR. With this combined approach, outcomes for truly localized disease confined to the nasal passages can actually be quite good, with reported 3-year overall survival rates around 85%.
What about advanced or relapsed disease?
Unfortunately, advanced or relapsed extranodal NK T-cell lymphoma carries a very poor prognosis, with a median overall survival of only about 4.3 months in some series. The most commonly used intensive chemotherapy regimen in this setting is called SMILE, which includes dexamethasone, methotrexate, ifosfamide, L-asparaginase, and tapicide. But even with intensive therapy, outcomes remain poor, highlighting the need for novel approaches in this setting.
Wow, okay. That was an incredibly comprehensive and truly deep dive into non-Hodgkin's lymphoma, based on Harrison's. We've meticulously unpacked its complexity from pretty much every angle, going far beyond just a simple overview.
Indeed, it really highlights the immense heterogeneity of NHL, which, as we've seen throughout this discussion, isn't really a single disease at all, but a whole spectrum of distinct entities, each with its own biology, its own clinical behavior, its own quirks, really. And the crucial role of specific genetics and immunology in its development, how these cellular errors, often arising from normal processes gone slightly awry, lead to malignancy. That's just a profound and transformative insight that continues to drive research.
And it underscores the absolute importance of precise diagnosis and staging. It's clearly far from a one-size-fits-all approach. Instead, it's this multifaceted strategy using sophisticated tools like immunophenotyping, detailed genetic profiling now, advanced imaging like PT scans, all to truly understand each patient's unique disease at a molecular level.
Absolutely. And that precision, that deep understanding, then translates directly into the varied and increasingly highly targeted treatment strategies we see, differentiating between aggressive versus indolent forms, using chemoimmunotherapy, stem cell transplant, and now these groundbreaking new therapies like CAR T cells, which are truly transforming the landscape for patients who, just a few years ago, might have had very limited or no other effective options. This isn't just abstract scientific progress, it's having a profound impact on human lives right now.
So what does this all mean for you, our listener, as you digest all this?
Well, it means recognizing the sheer complexity and the increasingly targeted nature of modern cancer treatment. It really shows how deep dives into specific knowledge, like this one based on a core medical text, are absolutely essential. Not just for professionals in the field, obviously, but for anyone wanting to truly grasp the nuances of medicine at an elite level. Yeah, it's about moving beyond just superficial knowledge to really try and master the information. Recognizing that intricate interplay of biological mechanisms and clinical manifestations, and understanding how that deep knowledge informs literally every decision made in patient care, from diagnosis to therapy selection.
So here's a final thought to leave you with. Consider this. Given the increasing annual incidence of NHL that we discussed at the beginning, and the complex interplay of environmental, infectious, and genetic factors we've explored, what future breakthroughs in prevention, or maybe ultra-early detection, might be on the horizon as our understanding of these fundamental cellular errors continues to deepen? What breakthroughs might be awaiting us just beyond the current horizon?
And perhaps reflect on the interconnectedness of seemingly disparate factors, like a common stomach bacterium such as Helicobacter pylori leading to a specific lymphoma, or errors made during normal immune cell development causing cancer years later. These connections reveal the hidden, sometimes unexpected patterns of disease initiation and progression.
If you found this deep dive intriguing, and we hope you did, imagine the countless other medical mysteries waiting to be unpacked. What other deep dives into core medical knowledge are you curious about? We'd love to know.